Okay, let us start, and good afternoon, everyone, and welcome. Thank you for being with us for our panel and discussion, Exploring Solutions, Homelessness, Substance Use, and Mental Health. I am Iman Hakim, the Dean of the Mellon Enid Zuckerman College of Public Health here at the University of Arizona. So before we proceed with our town hall event, I would like to remember Professor Tom Meixner, who was killed on campus in October. Dr. Meixner was a University of Arizona professor and head of the Department of Hydrology and Atmospheric Sciences. Some of our public health faculty worked with him on water quality projects. He was a beloved member of the university community, and he will be missed. So please join me in a minute of silence for Professor Meixner. Thank you. Also, before we begin, we respectfully acknowledge that the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home of 22 federally recognized tribes, with Tucson being home to the Tohono O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through education offering, partnership, and community service. So before I introduce our panelists for today, I want to personally thank Mary Gourier, thank you, Mary, who provided us with the opportunity to partner with Arizona Town Hall for this event to discuss these important topics. Mary, we also thank you for your dedicated support for public health and the college. We are honored to be with you all today and to the work with our panelists. I am pleased to introduce to you Liz Morales, the Director of the Housing and Community Development Department for the City of Tucson. Mari Vasquez, Community Risk Reduction Manager for the Tucson Fire Department, who also works directly with the city's manager office on their protocol efforts to help unsheltered individuals at the multi-agency resource coordinators. Deli Donnelly William, the MPH of 2004. So Kelly is the director of the Human Services Division at the Maricopa Associations of Governments. And we are also pleased to have a representative from our mobile health unit staff in Phoenix who work with the Street Medicine Phoenix program that brings services to the homeless. Catherine Miller earned her BS from the college in 2022 and now works at the Health Education Promotion Professionals. Thank you all and welcome to all our panelists. We are proud, So we are proud to partner with our sponsors, the University of Arizona Foundation, the Arizona Town Hall, and our beloved Zuckerman College of Public Health. The topics of homelessness, substance use, and mental health are all important and intertwined issues for our towns and cities here in Arizona. They are challenges that need public health solutions. To start our panel and discussion, I am pleased to welcome Tara Jackson, Director for Arizona Town Hall, who is with us today on Zoom. So Tara will guide the online discussion. I am also pleased to welcome Elizabeth McNamee in person. Elizabeth is the Vice Chair of the Community Town Halls Committee for Arizona Town Hall, and she will lead the table discussion portion of our meeting. She also has an MPH, way to go. So thanks for being here, Elizabeth. Finally, I would like to introduce Shepard Reed, our Director of Communications, who will moderate the panel. And thank you, Shepard. So now it is my pleasure to ask both Mary and Elizabeth to come to the podium to guide the program. Thank you, everyone.
Thank you. Before we get started, oops, that's loud. Before we get started with the panel discussion, I wanted to give you a little bit of history about the Arizona Town Hall, because I'm not sure many of you have had an experience with it. But the organization is more than, is that getting feedback? Oh, okay. It is more than 60 years old, and in that time has addressed a number of public policy issues through community discussions like these. And so it's evolved over that time, but what I wanted to emphasize is the process that the town hall uses to engage community in discussing issues that affect everybody's daily lives. Policy issues that range from water to air quality, to healthcare, education, taxation, government. All of the things that those of you that work in public health are very familiar with in terms of how they impact overall health and well-being of all the citizens of Arizona.
Thank you, Elizabeth, for explaining how the process works and for being here today. We're delighted to be partnering with Arizona Town Hall. We want to thank, of course, all of our panelists for being here. We also want to thank all of you for being here today to take part in this discussion. Iman, our Dean Hakim, introduced me earlier, and my name is Shipard Reed. I'm Director of Communications for the College of Public Health. And I'm privileged to be moderating our panel today. And so the first, let me see if I can find the right page here. The first question that we have for our panelists is to just introduce yourself. Tell us about the work that you do and how that relates to homelessness, substance use, and mental health. And we can just start at this end right here.
Wonderful. Thank you. Thank you for having me. My name is Kelly Williams. I work for the Maricopa Association of Governments. Our organization since 1999 has been responsible for applying for the annual HUD funding that helps with housing individuals who are experiencing homelessness in Maricopa County. And we consider ourselves a regional organization because we also work on the edges of other counties that are around the Maricopa region, and we also work with 3 tribal nations that touch Maricopa County as well. We receive, on average, $35 million a year to help manage programs, to help fund programs specifically for homelessness across the region, and we also, we cannot do this work without talking about substance use and behavioral health as well. I came into this position a year ago after working at the state Medicaid agency for over 10 years in behavioral health, and it is almost impossible, in my opinion, to separate those conversations.
Thank you.
Good afternoon, Liz Morales with the City of Tucson Housing and Community Development Department. Our department oversees many functions. Some of those include, of course, our federal housing assistance programs, in which we've created what we call a homeless preference. It's a mechanism so that we can get referrals into housing. We also oversee the Pima County's continuum of care, similar to Kelly's work, in ensuring we put together assist the board, what's called Tucson Pima Collaboration to End Homelessness Board. And so, determining the funding for that and adhering to the annual point in time where we go out as a community and survey and identify the number of people who are unsheltered. And we also have an area, and we've been doing outreach for several years, but most recently, Mayor and Council appointed a Housing First Director, and the goal of that individual, Brandy Champion, is to really coordinate and now, besides the outreach, we have navigators that really help those who are unsheltered navigate the various systems and trying to get people into housing. And we now operate shelters. We have 4 sites, hotels that we do non-congregate shelters. So our department has a variety of roles and work in this. But I will say my past experience also, when I was in the Maricopa County area in a nonprofit that did housing for persons who were seriously mentally ill and experiencing homelessness. Those 8 years were very pivotal for me in understanding the needs, doing lots of focus groups, surveying people. But I'll tell you what's the most impactful of, work experience, education, none of that even came close to my experience as a family member of someone who has a serious mental illness, also substance use disorder, and was homeless multiple incidents or multiple times living on the street. And so he was my best friend. He has since passed, but I learned the most about the system, the challenges of having a family member with both the mental illness and battling an addiction and being in recovery. So I will say that gave me my stripes in this work and helps me to be more empathetic and understanding to the needs.
Thank you.
Good afternoon. My name is Mari Vasquez. I am the Community Risk Reduction Manager for the Tucson Fire Department. I've been doing that for the last 2 years with the Fire Department for 9 years. The TC3 department is for Tucson Collaborative Community Care. It is a mutual partnership between Tucson Medical Center and Tucson Fire Department. We take our referrals from our fire crews that normally go to a call, and many times that call cannot be answered by a trip to the emergency room, and our crews don't have enough time to get to the bottom of what the root cause is for the person. The program started as a very reactive system. We used it for our system abusers, the 911 system, and now has changed to a proactive approach. So we do see the 4 categories that we have for the TC3 system are the aging population, but then mental health, substance abuse, and then those experiencing homelessness. So our department, what we do is we're funded by the Tucson Medical Center Foundation. They are 501c3. Since we get our referrals from our crews, sometimes they are to unsheltered individuals. And what we need to do is we have navigators as well. We have RNs on our team, we have paramedics, we have behavioral health providers and social workers, and what they do is try to find what the root cause of that person's issue is and navigate them to the right resources. For the last 2 months, I have also been working with the city manager's office with the new homeless protocol process. On October 27th, we were able to launch a new tool where individuals could report encampments to our city departments, and then we could get the right resources out to those individuals. We offer outreach to all the encampments that are reported if there are people living there. It's on a tiered system. We have 3 tiers. We work with environmental services to help clean up. We have our outreach workers that are part of Liz's department, and then we have the enforcement through TPD. So between all of that, I'm learning a lot, constantly learning new things. No case is ever the same. But I think the main thing that I would say about my experience is the importance of collaboration with other departments. Without collaboration and cooperation, it's impossible to get things done.
Thank you.
Hello, everyone. Thank you I'm sorry, was that loud? Thank you so much for having me. My name is Catherine Miller. I am from the University of Arizona College of Public Health up in Phoenix. I work with both the Mobile Health Unit and Street Medicine Phoenix, which are all part of the community outreach and engagement programs up there in Phoenix. I am a lead of Street Medicine Phoenix, which is primarily what I'm going to talk about today. It's essentially an interprofessional, interinstitutional project that provides medical care to people experiencing homelessness, mostly in the downtown Phoenix encampment. My job is sort of as a bridge between College of Public Health and the physicians who come out with us, UA faculty from College of Medicine Phoenix, medical students, a lot of medical students from CompP, in addition to a variety of medical students from other med schools, and one of the more exciting things that Street Medicine Phoenix has sort of brought to the Valley recently is this interprofessional collaboration, right? We have an optometry team. We have vet students from Midwestern who come and provide veterinary care for our participants' animals. We have social workers come out. We're getting nurse practitioner students. It's sort of a real, I guess, a real contribution of everyone in the medical field. And I think, in terms of substance use, mental illness, and homelessness, as all three have mentioned, there's no way to talk about one without leaving the others out. I think the biggest thing, in my work is seeing the medical students interacting with people experiencing homelessness, potentially for the first time ever, right? We have such a big group of medical students who come out and provide care with our physicians that a lot of times it's their first time or they only return every few months. And watching, the involvement of individuals who perhaps have gone to higher, Ivy League universities or something and have to come down onto the street and interact with individuals who've lived in a tent for years and, are using substances, I think is something that is a shock to a lot of people, but it's key to really bridging the gap with our medical providers, the new generation of providers who don't know how to interact with people experiencing homelessness. Being able to learn from medical director, Dr. Fowler, who has provided for people experiencing homelessness over a decade. You can't just treat someone on the street like you would someone in a clinic. It's never going to be the same, right? There's never going to be a follow-up. Or 9 times out of 10, if you refer someone to a hospital or to a clinic, they're not going to be able to get there. Their stuff's going to be stolen. They more than likely they're on substances, and they have very little funding to be able to get transportation, right? So there's a lot of barriers to providing medical care for people experiencing homelessness. And at the College of Public Health, we're kind of uniquely positioned in terms of having every avenue, right? Public health combines medicine, social work, any sort of social determinants of health that you can think of. We try to really bring them together, and that's part of my work and my team's work is how do we bring it to the people in the encampment, right? This is not about waiting for these individuals to call us or come to a clinic or something. This is how can we best serve the encampment itself. And I think it's an opportunity. It's honestly been an honor for them to accept us. We have a great relationship with the encampment, and I think we're really lucky that they have accepted all of us. Having a massive team of medical students and doctors walking down with stethoscopes around their necks is pretty unique. It's a street medicine is not a foreign concept. There's a couple hundred programs around the world, but I think we're lucky to be able to be one of them in Phoenix, and so hopefully that provides a little insight into what I do and what my team does.
Thank you, Catherine. And that happens to lead right into my first question for our panel. And that question is that access to health services is often a problem in underserved communities. And what access challenges do you see in your work, and how can a public health approach help us to meet those challenges? And I think if anybody wants to just jump in, please just start off the conversation. Thanks.
Sure. So I think historically when we've thought about homeless people, we've thought about Lieutenant Dan from Forrest Gump, right? An individual who had PTSD from war, who had a physical disability, who may have come out of it using substances. Homelessness today looks very differently than that. We still have a significant veteran homeless population, and I am in no way trying to downplay that. But I can tell you what the data is showing us in Maricopa County, which is very similar to what the data looks like nationally. We have 30% of the kids who age out of the foster system are ending up homeless. They have no one. They have no resource to land on. They don't have any family members. They don't have a couch to end up. We also have a significant increase in seniors who are on a fixed income who have never been homeless before. They have completely different social needs than someone who's been chronically homeless living in an encampment, for example. Their health needs are different, their resources are different, et cetera. And so I think when it comes to trying to identify specific populations that need more care, this is not a one-size-fits-all program. I really think that if you've ever had the opportunity to walk alongside someone who is experiencing homelessness, you know that that is just one person's story. They have very specific needs, whether they're health needs or substance abuse treatment needs, or connecting with a family member who's on the East Coast, or whatever that might look like, right? Everybody's situation is a little different. And so I really strongly, and this is not just my personal belief, backed up by lots of research, you probably all know this, but the way we get out of this is we build a stronger social net across the board. We talk about affordable childcare. We talk about long-term benefits for children coming out of foster care. They are still kids, 18-year-old kids, right? We talk about what does easy access to substance use treatment look like? And we talk about how do we, I'll just give you one creative solution that we're talking about in our office right now when it comes to seniors in particular. We're looking at specifically using GIS data, we're looking at pockets of communities in the Maricopa County area where you have a really high rate of older adults, whether they're snowbirds or whether they're people who live there full time, and trying to figure out if there's a way we can develop an app for shared housing. So think about it like a Match.com, where you have one senior living in, let's say, a trailer, whose all of their rent, their groceries, everything has gone up, but they're getting the same amount of money every month from whatever income source that might be. Their neighbor, 4 trailers down, may be in the same position, but they don't know each other. How can we come up with some technology that adults or youth, but for this specific project, where they would trust it, where we could get them together to be able to share and co-share those expenses in a roommate situation, rather than just adding 2 more people to our list of individuals who are unsheltered across the region. I think we're going to have to start looking at this differently in both how we house people in general, whether, the latest data I saw, which made me sick to my stomach, is 80% of the current new building that's happening in Maricopa County is luxury build. None of us can afford that. That's a second, third home for some Yahoo who doesn't live in Phoenix year-round, right? That does not come anywhere near addressing the homeless issue that we're having in our community. So how do we have more in-depth conversations about not allowing that sort of investment to move forward, but instead looking at the infill pockets of land we have, where we know we have communities that need dense multifamily housing with access to health care.
So in talking about what are the challenges of accessing health services, one of the things I think it's important just to acknowledge that when people are living in a state of unsheltered or homelessness, they are not prioritizing their health needs. They're in survival mode. A lot of them have experienced or are currently experiencing trauma. And so their ability to really address the things if they know they have diabetes, if they know they have some other health conditions, or even just the elements and the use of the substances could create new health conditions, right? So one of the things we know is the hardest part to access is engagement, getting people to engage with us, and I know that Catherine can speak better to that, but I do have 3 examples of ways we can use public health approach a little bit better. I think one of the things that really came to light in this is when the pandemic happened in March 2020, and we started realizing, we were hearing from our shelters, what do? We need to social distance. How do we social distance in a congregate shelter? So, and the unsheltered, how do we protect those that are living on the streets, who are either seniors or have conditions that make them more vulnerable to COVID? So one of the things we did is we created a screening tool, and we used it in the shelters. We used it with outreach teams. With Al Rio provided a team with our outreach team, and they went out and assessed people. And as we identified people who were highly, I'm forgetting all the words that we used, but basically very highly vulnerable to COVID, and we put those individuals and families into hotel rooms. That was one of my first kind of understanding of how that public health piece was so critical to working with people in shelters and on the streets. Second, being able to have that team, Madi can speak to this, but when you have a public health approach, there's some things you can do: immediate basic care, medicine, pharmacy type management, coordinating those in-office kind of appointments with people. And we need, and I like the term, this is something we brainstormed before coming here. I wanted to hear from my team who do this on a daily basis, and having clinical services without walls, which I really like that term. So having our health teams from our health clinics going out to the shelters, that has been very successll to have them going straight to the shelters, providing the medical services on site. Our public housing site, we have a 17-story, 408 units of really highly vulnerable people. It's called Tucson House. During the pandemic, we had healthcare coming on site. That was huge and very, very helpful. Finally, for our continuum of care, our collaborative application, we are submitting a proposal, which I think, whether it's funded by HUD or not, we're going to figure out how to fund this, where we're going to include outreach medical and mental health providers as a team, Old Pueblo Community Services, Streets to Home program, and the Home Health Hope, which provides a medical nurse practitioner with the mental health nurse practitioner, and they will go out and provide services in that collaborative kind of partnership. So those are some examples of what we can do. And once they're in housing, many times we're just getting people from shelter, from either the shelter or the streets right into housing, getting people enrolled with access, getting people enrolled with benefits. Those are really critical things to do quickly. But bottom line is we know we can't do those things unless it's much harder to do it if they don't have a roof over their head. And so that's the goal is in all these efforts is let's get them somewhere, because being able to access public health or support for their health is much better when they have a place to live. Oh, thank you.
Oh, I see there's a question out there.
So back then it was not, we do the SPDAT now, which is a way for us to place people on our, what we call the coordinated entry, and identifying their level of severity as far as issues. Back then we used a tool basically out of the CDC that evaluated how vulnerable or how vulnerable people were to the pandemic and prioritized those people.
So as far as engaging goes with the unsheltered population, one thing that the TC3 program has done is try to get buy-in. A lot of the times the trust is not there. And so what we did is we approached PetSmart. They gave us a $125,000 grant for 2 years. And the way we tried to submit that trust or intended to initiate the trust was by telling them, looks like your animal may need to go to the vet. Would you like us to take your animal to the vet and get some shots? We're really worried about you, and we want to be able to take care of you as well. But making that effort to take care of their animals, many times they will buy food for their animal, their dog, cats. We've done anything other than you can think of. before they eat themselves. And so providing that trust to them to say, listen, we're going to help you with your animal. We can board them in a safe place with the promise that when you're stable, you can get them back, has helped us make connections with a lot of people. So just as an example, I think, because I agree with everything that was said before, but that was a way that we could allow the access, as well as taking our iPads out and having them, talk to their providers where they are and answer questions, and having our nurses take a look at, the last time they've been to primary care, if they needed medicine, we could go to the pharmacy, get that filled, and bring the medicine back to them. So just some examples.
I think one of the things that I really try to emphasize with maybe individuals who haven't worked with people experiencing homelessness is the actual impact on their health. I know when, public health means everything, it's not just health status. But when we talk about public health, it's important to talk about health status, right? And if you think about the spectrum of individuals experiencing homelessness, I'm just going to speak about the ones who are sort of on the most vulnerable end, which are those living in encampments, just because that's the work I do. But in terms of health status, I have genuinely seen a handful who do not have any health, any health problems. And the reason I say that is because when you're living somewhere, not living somewhere, right? When you're unsure of where you're going to sleep, when you're always in danger, you're always exposed to the elements, you're always constantly under stress. I mean, it generally changes your brain chemistry, right? The trauma, the prolonged stress, the chronic stress and the chronic trauma, not to mention the physical stress, right? Potentially, being in danger physically. There's a decent amount of violence that goes on with people with mental illness. I think it's important to take into account that there will always be health problems, right? And public health is everything. Public health is health status. And so when you address a health issue, it's important not just to consider, I think, including in my work, a lot of it is medical care, but to get to the root of the problem, as we always speak of in public health, is the social determinants of health, right? What are the determinants of the health status? And going in every direction, as Kelly mentioned, maybe people aging out of the foster care system, or individuals in medical debt for whatever reason. If they're homeless, there's so many other reasons. And in public health, it is our responsibility to sort of shine a light to everyone, not in public health, and show how every factor can basically impact your health. And I think just giving the context of that to people is important because, public health is everything. That's the biggest thing I can kind of get across, especially for people experiencing homelessness. There's not one reason that someone is ill. I think, I don't know, I guess the biggest point is just medical care is sort of reactionary, right? If we can prevent any medical issue from happening, that's the biggest problem.
Thank you. I have another question, and I realize I think Amber can watch for hands if hands go up in the audience, and all of you have questions for our panelists. We'd be curious to hear them. But I do have I have another question, and it has to do with the pandemic. And I know Liz touched on this, but certainly the pandemic has been stressful for all of us. And I think across our society has increased mental health difficulties. How have you seen that the pandemic impacted homelessness and substance use and these intertwined problems? Is there a very distinct before and after?
I had the opportunity to speak to some public health students last week, and one of the questions they asked at the end about the pandemic was like, what is your biggest takeaway from working in homelessness during the pandemic? And I think as a public health practitioner, someone who just absolutely is still in love with this field and is very proud to go to work every day, public health cannot be political. And I think as long as we allow public health to become political and we don't rely on data, we are going to get ourselves into a world of problems, whether it is a poor response to COVID or monkeypox or RSV or the next thing that's coming down the pipeline. And our most vulnerable will suffer the most. And we saw that with our unsheltered population in COVID. You have individuals who do not have the opportunity to socially distance. They are living in tents next to each other, overcrowded, often in encampments or for those who were able to be inside in a shelter, the shelter beds had to reduce greatly during that time because, again, they were going up against new standards of trying to help keep people safe. And it, interestingly enough, it really created a lot of resentment among the provider community for folks who work with individuals who are experiencing homelessness, because all of a sudden you had frontline workers who had to go to work every day and be around folks who may have COVID and expose themselves every day. There was no opportunity for them to work from home. And then you had people like me who had an administrative job, and I could do my job from the safety and security of my home office. And we're still working through some of that as well. I think COVID is just one example of how when you have a weak social net and you have a health issue that is politicized, and you will have people die unnecessarily. And we definitely experience that both in our unsheltered population and in the general population.
I also think the issue of solitude during the pandemic greatly affected mental health, substance abuse, and then down the line, those that are unsheltered. We had, just every time we would talk to somebody coming out of the pandemic, the amount of loneliness they had, the amount of stress that caused them to be away from family members. I think that was one of the big things that we saw, is just the solitude just exacerbated the problems.
One of the things we, in talking with the team, the increase in the number of the use of fentanyl was significant during the pandemic. The Arizona Department of Health reported that through October 6, 2022, there were over almost 2,300 non-fatal overdoses, which was a significant increase. So, can we explain why? I mean, I won't venture to make why, but we know that was one of the outcomes of the pandemic. I'm glad, Madi, you talked about the isolation, the loneliness. That's already part of the virtue of being unsheltered, where you feel invisible or, not part of the society. But COVID definitely made it that much harder. I think some of the things that we've learned from that is we need to still try to promote some social recreational community building activities. We think they don't want to, have some sort of activities, but in a lot of the ways that we can do that, many of them with the encampments, we've seen an increase of creating community, and I saw that a lot through the pandemic. Now, instead of people kind of individually camping, now they're forming large encampments. So where we used to place people here and there, now they're forming like their own community. One of the things we did when we opened the one hotel that we purchased is we targeted one large encampment, and we moved that. We pretty much engaged almost every single one of them, over about 70 individuals. Some of them were housed together, some of them were in different tents, but they all moved together over to Wildcat, and it was really impactful for them because they continued like their family life. They had a woman who was kind of like the mom of the group, and a couple of the men who kind of told everyone else what they needed to do, and it really seemed to be, that sense of family continued. So you don't think it's possible to do that, but there is a lot of potential to do that. Also, harm reduction, I think, is one of the important things that we have to recognize that we needed to do in providing naloxone and Narcan distribution was really important. Education and access to low barrier shelter was really critical to help address some of those issues. And I will say this, that ultimately, in order to address these needs, you might hear me say this more than once, housing has to be the priority. without the safe and stable housing, it makes it extremely difficult. So the pandemic taught us that the eviction moratorium, I'm sure many of you heard about that. Even if we had people, we could connect them to housing. We couldn't find units because there was virtually no available units. That was really tough through the pandemic. But without that, we couldn't really serve people because of the lack of units. And then, of course, the increased rental costs made it very difficult too. So pandemic hurt us in a lot of different ways. So, yeah.
Thank you. We just have we have a question out here. We just have a few more minutes before we'll wrap up the panel and move to the table discussions, but jump in.
There we go. Thank you. Hi there. Oh, that's loud. So I'm a master's student at the College of Landscape Architecture, and I was just wondering if you guys had any ideas about like innovative ways of creating public spaces that better serve these communities. So I've noticed just from my observations of going around in Tucson that a lot of these homeless people congregate in city parks that are not, these parks I would argue are not even suitable for the community that is not homeless, much less for the community that is. I was just wondering if there's any ideas that you guys wanted to share that I could potentially share with my college at some point about how to create better environments for homeless people in these settings.
I would start with a don't. The washes are a big issue, especially for fire, so I'm just going to talk about my history first. I think a lot of unsheltered individuals sometimes come during the nice part of the year where it's not the monsoon, we don't have a lot of rain, and then as soon as the monsoon hits, we're trying to usher them out of the washes because they haven't seen flash floods. I think that's a great question. I think usually we look at the landscape picture through crime prevention, right? Like the CEPTED, crime prevention through environmental design. So making sure your shrubbery is low and it doesn't cause a vision issue for the businesses. But I'll be honest with you, I've never really thought about the lens of shifting that to see what it would look like to offer a more acceptable living condition for somebody in shelters. So I hope.
Well, I mean, just to add on to that, like some potential ideas that have been running through my head are like, why don't we have parks that actually produce things that people can eat? Like these are the places where they're congregating, and it's just my undergrad public health idea that you just use what's already happening and just fix it. So like, or try to make it better, So these encampments are gonna happen until we find housing, which, I mean, based off of the numbers that 80% of our new buildings are luxury, I don't know that that's gonna happen anytime soon. So we need faster ways of dealing with things. And I feel like this could be kind of a faster way of helping these communities.
I will just add, I don't have any answers for you, but I love that you're thinking about it. Because what I will say is we have approached homelessness the same way since the 1960s, and it is not working. If it tells you nothing else, and it's not that it isn't for a lot of hard effort for a lot of people and a lot of money, we have to start looking at this with new creative ideas to try to figure it out. So I have seen, unfortunately, lots of architecture that's specifically designed to not allow homeless people to sleep there or individuals experiencing homelessness. So I just want to applaud you for the way your brain is thinking. And my first impulse when you asked your question was more bathrooms. We always need more restrooms, especially in areas of encampments, congregation, where people are in mass amounts. That's where you get other public health issues come up when there isn't an ample space for people to be able to use a restroom safely.
Great question, and thanks so much. And we've come to the end of our time for the panel, and we're going to shift over to our table discussions. So thank you to our panelists for being with us here today.